In this video, Professor Dasgupta explains key considerations when monitoring patients with giant cell arteritis.
I think the most important point to make here is that monitoring of patients with GCA is not a monolithic, one size fits all guideline. It depends essentially on stratification of the patient. So, a patient who has remitting disease with giant cell arteritis will require less monitoring compared to the patient who has got more difficult to treat the disease, such as relapsing disease, such as refractory disease, such as disease associated with ischemic events, such as disease associated with serious side effects related to corticosteroids. So let's start with monitoring patients who have easy to treat remitting disease. These are patients who actually come into remission with purely a dose of corticosteroids. For example, cranial disease in GCA, which is not associated with ischemic complications. These patients, you would start with 40 to 60 milligram prednisolone, and if they have a good response to that sort of treatment regimen, so you reduce to 30, 20, and then by 2.5 milligram. And once you've come to a dosage around about 10 milligrams daily, which is something that you reach around 6 weeks to 8 weeks, then you can ease off in your stringent monitoring requirements. And these are the patients then you can actually then follow up every 3 months while reducing the dosage by a milligram daily each month. And then, in fact, you can go on to a 6 monthly monitoring, provided these patients do not experience a relapse or have any other complications related to the GCA. Now we come to the group of patients, around about 30 to 40%, who represent the more difficult to treat patients, the patients who start flaring once you reduce the steroids down to around about 10 to 15 milligram prednisolone. So these are the patients where you need to monitor them much more often. So initially you started the patient on your high dose steroids, and after a month, when you see them, they're doing well, but you find suddenly that the CRP is creeping back. And these are the patients you really need to follow on a monthly basis, because you've already stratified the patient into the relapsing category, and now you want to make the treatment stratification. So you need to then add on to the tapering dose of steroid. You want to use disease modifying agents such as methotrexate, such as leflunomide, or you may want to go on to biologics treatment with use of medications such as tocilizumab. And so your stratification, which is dependent not only on clinical basis, but also on the laboratory basis, such as patients who don't reach a normal CRP of 5 or less, or imaging stratification. And once you've then got them into remission, whilst using DMARDs or biologics, then again, you can ease your foot off the accelerator, and you can give them 3 monthly gaps and intervals in which you look at their disease activity. So the bottom line is that patients who are not doing so well, you need to monitor carefully, get them onto your DMARDs or biologics. Once you've got them settled on these drugs, then again, you can actually see these patients on a longer interval basis. You must, in your monitoring, always make the space for monitoring these patients if they have flares. Now, we come to then a difficult group of diseases that we see in GCA, particularly the ischemic subset. Now, we've got this group of patients belong to the really elderly patients above 80 at least, and they present with ischemic complications such as sight loss and anterior ischemic optic neuropathy or central retinal artery occlusion. And these patients, while you're reducing the steroids, you really have to be very careful because upfront there is this the potential threat of further ischemic sight loss while you're reducing the dose of steroids. So you really need to follow these patients very closely in the first 3 months, and then again, if they become stable, you give them a longer interval for coming back to the clinic. The fourth group of patients where you need to really look at them carefully are the group of patients who have risk factors for corticosteroid side effects, such as patients with diabetes or renal impairment, or patients who are vulnerable to chronic infections, such as who wear catheters, chest infections, bronchiectasis. These are the patients you really need to monitor carefully while you're supervising your steroid therapy, that they don't get infections. So to end this whole discussion, you need to stratify the patient into the easy to treat remitting group, which is usually the cranial GCA without ischemic complications, versus the more difficult to treat disease with relapsing disease, refractory disease, ischemic side effects, or patients who have corticosteroid related complications, serious adverse events.